objectives for this presentation are to discuss and analyze the pathology of myofascial pain patterns, identify and evaluate causes and contributing factors, discuss clinical manifestations and functional limitations, review diagnostic tests and measures for assessment, differentiate myofascial pain from similar conditions, and outline in detail the rehab process for effective management.
Alright, so today we're talking about myofascial pain. This is musculoskeletal pain originating from muscle and fascia. This is due to hypercontracted muscle, which is just very tight muscle bands. And then it has a presence of trigger points. Now, a trigger point is a hyper irritable spot that is located within a taut band of muscle. It may be active, latent, or associated. Active is causing pain during rest or movement. Latent is painless unless it is provoked, and then associated is either found in referral zone of another muscle or activated by overload due to compensating for a primary trigger point. So this can cause localized or referred pain, and it can be acute or chronic. Acute may resolve quickly after simple treatments, where chronic may last to 6 months or longer.
Alright, here I just added some pictures of the upper extremity pain patterns. As you can see, like the circle or the dark red circles, there's going to be the trigger points, and then where you see the shaded areas, that's going to be where the referred pain is. So if you look at the pectoralis major, you can see where the trigger point is, and then patients would experience referred pain from the trigger point in the chest, front of the shoulder, down the inside of the arm, and along the inside of the elbow. And then with this, they can have possible tenderness and nipple hypersensitivity. And then the same with the lower extremity pain patterns. You can see those darker red areas, that's going to be the trigger points, and then where it's slightly shaded, that's where the referred pain is. And then one of the common ones is going to be in the piriformis. You see 2 trigger points here, and then they just have radiating pain down the posterior thigh. For pathomechanics, according to the textbook, the direct cause of trigger points is not completely understood, but here are some of the potential causes. Most of them are going to be due to unaccustomed exercise or movements, bad posture, or like if you're moving patients, you're not having those proper body mechanics. So you have muscle contractures, muscle overuse, direct trauma, unconditioned muscles, partial stress, lack of proper body mechanics, and then stress and anxiety.
Some of the clinical manifestations is our signs, which is reduced range of motion, which can often be due to just pain, weak muscles, the trigger points, referred pain patterns, and then some of the symptoms would be sore tender muscles, fatigue, and then pain is often described as aching, throbbing, tight, or stiff pain.
All right, and then for functional limitations, most of them are going to be due to the pain that's caused by the trigger points. They're not going to want to do anything that's going to cause any more pain or intensify the pain. So that's going to cause decreased range of motion, muscle tightness, resistance to stretch, impaired muscle function, reduced physical endurance, and difficulty sleeping throughout the night.
Just some of the testing measures. So palpation is the gold standard. This allows you to feel for like the presence of like taut bands, trigger points, and then range of motion. You'll often see a decreased range of motion this due to pain. Manual muscle tests, and one thing I didn't put on here is muscle selection tension test, which you can see painful range of motions, and then again now it's just viewing like the asymmetries of the muscles when people are walking.
All right, for differential diagnosis, the main one that gets confused with myofascial pain syndrome is fibromyalgia. Fibromyalgia is just the widespread of pain and tenderness. Instead of the trigger points, you're going to see multiple tender points, which are going to be 11 to 18 specific sites throughout the body. This condition has chronic pain that lasts above 3 months in the scapula, head, neck, chest, and lower back areas. Symptoms usually develop from physical traumas. So if the patient was in a car accident or they had a severe fall, that could be a cause for this. And there's a fluctuation of symptoms, and there's a higher incidence of tendinitis, headaches, and anxiety. And here I just made a Venn diagram from a chart that was in our Derek's textbook. So as I stated, with fibromyalgia, there are specific sites of tenderness versus with NPS, there's trigger points. There's an absence of referred pain patterns in fibromyalgia versus with NPS. You have those referred pain patterns that we saw in the pictures earlier. There's absence of taut band in the muscle with fibromyalgia, but there's a presence of the taut band in PS. And then with fibromyalgia, there's usually severe tiredness and fatigue, but with MPS, there are usually no complaints of tiredness. And then here's just a picture of those 11 to 18 specific tender spots throughout the body with fibromyalgia. And then just a few other conditions that can mimic myofascial pain patterns is arthritis, neuralgia, tendinopathy, and bursitis.
For the rehab process, according to our Therex book, the treatment consists of 3 main components. It's correcting contributing factors, eliminating the trigger points, and strengthening the muscles. So the maximum protection phase will often have like decreasing the pain, which can be done by trigger point release modalities, contract, relax, stretch techniques, and then correcting contributing factors such as patient education, talking to them about posture, their lifting techniques, things such as that. And then some muscle endurance exercises like walking, scapular stabilizing exercises, and core stabilizing exercises. For the moderate protection phase, you continue to do interventions that decrease pain, modalities, stretching, continued correction of chronic overload factors, just as the bad posture, the repetitive activities, lifting techniques, and then begin light resistance exercises with the scapular stabilizing muscles and the core stabilizing muscles. Okay, for the minimal protection phase, just the same thing, continue interventions focused on decreasing pain, as needed modalities, stretches, ramping up exercises for return to work, just exercise specific for their line of work, and then patient education just on the continue of exercising to prevent trigger points or for it to come back, and the correction of their body mechanics.
Alright, and some of the potential outcomes with treatment, the main goal is just centered around reducing the pain and eliminating the trigger points and just getting them back to their normal function. So with this, we would have improved muscle function and stability, decreased localized pain and tenderness, reduced muscle tension and inflammation, improved posture and stability, quicker healing and muscle recovery, and restoration of normal function.
Myofascial pain syndrome is characterized by presence of trigger points. It's described as dull aching and deep pain, caused from a muscle injury or strain. Examination includes palpation, manual muscle test, manual muscle selection tension test, range of motion, and normal healing time is usually 36 months.
Alright, these are our references.
So now, clinical manifestation, right? So another clinical manifestation that's not on here that you need to be aware of is called NSR. Anyone know what that stands for? Noceo septive startle response. So what is a nocioceptive startle response? When you palpate on the involved soft tissue or the trigger point, the patient will try to move away from that pain very quickly. So they're gonna present with a response to where they try to move away from that pain. So if you have anybody who has very tight upper trapezius muscles, and if I go to squeeze the muscle, they will try to move away from it. So if they have a tight upper trapezius on the left, and I just go squeeze it, they're gonna say, oh, they don't like that. They're gonna move to the right. So they're gonna try to move away from the pain. Or if I strum the levator scapular muscle on the right side and it's very tight, they're gonna move to the left side very quickly. They're gonna try to move away from the source of the pain. And so that's a nocioceptive startle response. And that nocioceptive startle response is gonna occur with the palpation.